This is our first digital health visiting speaker series, and we're have a very, very special guest here. I'm just Keeler. He's widely known as the Health API guy, and just look at all the socials and you'll understand why. He's a leading voice in healthcare interoperability and data liquidity. He has a rich background spanning from roles at Epic, Redox, Zeus Health, Flexpa, and now is the interoperability and liquidity practice lead at HT. Did I get that right?
That's a big. I want to go short.
So he brings deep understanding and expertise in connecting healthcare systems and unlocking potential in data exchange. And through his popular newsletter, I have to plug it, the Health API Guy. Subscribe to it. It's very, very informative. And his advisory work with innovative health tech companies, he's become the go-to resource for navigating the complexities of digital health. So get ready for an insightful dive into the future of healthcare, interoperability, and data liquidity. And as a treat, we get a sneak peek at his HIMSS keynote happening soon next week. So he's going to give us a
first run. Bumps. I appreciate feedback.
So welcome. Yeah,
Take it away. Thank you, Oliver.
Do you want me to set up your slides?
That would be great.
Awesome. Okay.
Well, thank you for that intro. As mentioned, this is, there's a couple ideas of which presentations to give, what to focus on. This is focused on health information exchange, the infrastructure we build between organizations. So less about the developer tooling and things like that, but more how do we connect our ecosystem so there is an analog and manual process. Thank you.
Next week. So.
This is a presentation that's made for HIMSS next week, largest healthcare conference in the country. This is the sneak peek. Away we go. All right, that's my background. Oliver introduced me. I've worked in data interoperability from different lenses, Epic, connecting health systems together, but also the systems that orbit around Epic, mostly abroad in the Netherlands. Redox, helping applications connect with one API to all EHRs when you are selling as a business associate application. Zeus Health, founded by Jonathan Bush, founder of Athena Health, cousin of George Bush. He's a very fun and charismatic individual. It was a wild ride, but that is health information exchange and infrastructure. Come on through, guys. Flexpa, so I left Zeus and went to Flexpa, which is a sort of plaid for payer data. So connecting to insurers and pulling claims data for a variety of use cases, selling B2B. And then now I'm the interoperability and practice lead at a digital consultancy and development agency, HT Health. I now live in Portland. So, newsletter, and then I'm on the Care Quality Steering Committee, which is the largest health information network in the country. No conflicts of interest. Here's our agenda. We're going to go through the landscape of interoperability standards, talk about infrastructure. We're talking about the three main models: health information exchange and infrastructure, not just in healthcare, but literally in all infrastructure and rails that we build digitally. We'll talk about challenges and barriers that stop this from happening, why we're not there yet. We'll talk about regulatory requirements and incentives, and then some emerging trends and innovations, maybe beginning with A and ending in I. But before we do, and then the fun ancillary objectives. I like scales, axes, things you can sort of visually see. So there'll be a lot of those, some of them humorous, some not. Frameworks are always good to stick around and think about ongoing. Memes are funny. And then hopefully you are like, I want to be involved in infrastructure. So these are my opening monologue or notes. So bear with me here. 107 years ago, plus or minus, our predecessors brought forth in this industry a new vision, conceived in innovation, and dedicated to the proposition that health data should flow freely. It's not Monday, it's not early, and it's not Vegas, but imagine you're in Vegas. I'm unbelievably impressed for all of you being here. You will be rewarded. This is Sin City. This is Stanford. This is the city that never sleeps, the city of entertainment. So this is not just some dry academic lecture. It's show business, baby. You will be entertained. There's a common question I hear about interoperability. Why are we not there yet? We've been at so long. How can it be that we're not done? I'm constantly surprised by that question In fact, I turn it around. Why do you think we'd ever be done? To go really highbrow and metaphoric for a hot second, the human condition is to strive, to seek, to find, and not to yield. Whatever we create, whatever we do, we will not be content. The buildings we build will fracture and decay. The assumptions we make will fail with time. The buildings that we, that's the wrong sentence. The indomitable progress of time means that future generations will look upon the monuments of our era and wonder at our hubris, our blindness, and our own limitations. And so we know this, the health information exchange that we do today, the infrastructure that we create, are inherently and undoubtedly imperfect. They will be tossed aside in 5, 10, even 3 years. Whatever's invoked now will be broken by the unexpected technologies of tomorrow. This is not a message of futility. This is quite the opposite. It should be extremely empowering to know that interoperability, like any goal that we pursue, is not the end stage, but a continued path of improvement. In that light, we can pride ourselves on the progress that we made, the problems that we fixed, and the lives that we saved, rather than flailing helplessly against the impossible standard of perfection. We build today knowing full well that the solutions are temporary, addressing the needs of the moment with the tools and understanding available to us now. So I open with this very simple statement. Interoperability is just a series of tubes. I riff on the quote of the late President pro tempore and US Senator Ted Stevens to highlight not just that interoperability when it's a buzzword, it's a superset of all the infrastructure that we need to build in healthcare digitally. We are tube builders, the plumbers, the connectors, responsible for building upon the foundation modern healthcare will flow. Like the water systems that transformed public health in the 19th century, we are constructing digital pathways that will enable 21st healthcare delivery. And so, we live in the most interesting of interoperability times. We live in the times of unbridled successes, of ubiquitous infrastructure, of mass digitization of analog workflows. We live in the times of abject angst, strife, antitrust, and information blocking. The 21st Century Cures Act was passed almost a decade ago, and we've seen the pendulum swing from legislation to regulation, and now to litigation. Shit has gotten petty out there. Tensions are high. We pedantically debate the contours of the definition of treatment when patients can't access their records, schedule appointments, or pay their bills. We live in the times of a new administration, of rapidly changing regulatory prerogatives, a policy akin to a blindfolded dart thrower. I used that one with you earlier. An expert once said, chaos is Aladdin. And why Peter Baelish, master of coin on the small council of King Baratheon and King Joffrey Baratheon, operated in a very different legal and bureaucratic framework than we do today, he's directionally correct. The chaos of a new and unpredictable leadership is a time to reinvent what we do and build something better. We live in times of acute attention to healthcare, of skyrocketing costs, of worsening outcomes, of rising discontent in the system that serves so many poorly and serves so few well. And here we are in the most interesting times, Stanford, Las Vegas. Some have said this is the most ironic, hypocritical city. This makes more sense when we're in Vegas. In the world, to have a healthcare conference. Are we some people? No, we're the Stanford Biodesign people. We're not some people. We're builders, and we're here to build. So, that's the opening monologue, hopefully entertaining. There's a series of famous people presenters. You're gonna get a little bit of that out of me. You can get some Judy Faulkner. She's the CEO of Epic. She likes to, pedantically go into detail. I might do that from time to time. You're gonna get a little bit of Jonathan Bush on the other end of the spectrum, maybe jumping on a chair, throwing some wine on you. And then Steve Posnack or Mickey Tripathi from the ASCP, kind of kind souls with, maybe a Dr. Seuss memoir or some metaphor, or Anish Chopra, former CTO under Obama. Or maybe you'll just get me. I'm here with the G.I. Joe principle. I want to teach. Knowledge is half the battle, so hopefully you learn something. Maximus, I want to entertain. Hopefully that's clear with some of the metaphors and jokes. And then the Dewey principle. If I'm wrong or erroneous or say something that's not factual, correct me kindly. I'm sorry about that. So what's the current landscape? I want to break things down a bit. As we think about interoperability, it is a buzzword, it is overloaded, it is something that makes no sense to people because it is 100 different things all commingled all at once. And so you say, wait a minute, what is SureScripts? What is health information exchange? What is patient access? And so by breaking it down to the 3 different domains, you can start to say what actual problems that you're solving, what tools are available to you. Intraoperability. I'm an organization. I'm a healthcare organization. I'm Stanford. I have my Epic instance, but also my PACS, my DMS, these other things. That integration is one problem set of how do I stitch together my organization, my enterprise to work seamlessly. So very important. It's how I start my career. Kind of not the focus of today. When I talk about interoperability, I'm talking about infrastructure between all the organizations that exist and communicate and that need to use fax or phone or anything to communicate back and forth. And so those covered entity to covered entities, you know, the payers to providers, the providers to pharmacies, the pharmacies to PBMs, any entity type, if you imagine them communicating, if it's a phone call or it's a fax, we're not there yet. There's something we can work on. And then there's patient authorized exchange, increasingly popular, increasingly mandated by regulation, allowing patients access to their information in different ways. We've been on that journey since HIPAA, and we're not there yet. We haven't made it easy enough. You can't pick up your phone and see all of your records from all your healthcare institutions. That's the end goal. Today we'll focus on that middle piece, but I'm equally passionate about the other ones, and we can come back and do a different one for the other topics. How are we doing? Well, many people say, we're not using FHIR yet. We're not using the newest standard. We're failing. That's bullshit. You're wrong. One factor, it's the least important factor when building infrastructure at a national scale. For any interoperability workflow, what actually matters is ubiquity. Can I do that ubiquitous? Can I send the e-prescription and does it work with every pharmacy? Can I pull from every provider? Can I submit a claim to every insurer? Or are there phone calls, are there faxes? Is there administrative work? As we build national infrastructure, we look for ubiquity first. I don't care about the standard. I care, it can be, from 1880. But if it's ubiquitous, then it's digital, and it's digital, then we've upgraded over the high cost of manual workflows. So if someone in the back office making a phone call, and we can start to do really fun, nifty things with that digital information. And so people say, why is fax still around? Why is phone still around? It's because it's ubiquitous. Everyone has it. Because it's flexible. You can do it for any workflow. Until we can meet that standard with digital infrastructure, we're going to continue to fall back to something that has the ubiquity and flexibility. And so then after you get past ubiquity, after you get past the flexibility to do many different things you might want to do, you get the cost. And things like, is CDA a costlier standard? Is it better to be using FHIR? That's the last, that matters so little compared to actually connecting all the different systems together. So just a little scale, I promise you scales, thus you can see it. So over here on the left, you see things that are point to point. When you're just getting started building infrastructure, you say, let's communicate back and forth, just us, Hey, you like HL7B2? Let's do it. Say no to that. It's the dark path. But when you start, you say your partners, let's just prove it out. Let's do it between us. I'm a provider organization. I'm Stanford. We're close with, I don't know, Kaiser. Probably not Kaiser, but a different insurer plan. Let's do some nifty electronic prior authorization. Very popular right now. You don't do that national scale to start, but you start point to point and you progress. You start to build local networks to do those things. You build atomic networks in Silicon Valley, France. You build up and get broader reach and incomplete reach. And so things like care quality, direct trust, these are nationwide networks that provide tremendous value, but they only reach 70% of providers. Until they're ubiquitous, I can't use it for everything. And that's all that matters is ubiquity. And so as you keep going up, clearinghouses, okay, wait a minute, I can submit a claim as a provider and it can go up and I can do eligibility checks for almost every insurer in the country. You don't have to do manual processes except for edge cases on edge cases. Same thing with SureScripts. I can place an e-prescription. When I started my career, that was not the case. We were still printing out some scripts to take to the pharmacy. You go to other countries, this is a different scale. You go to Canada, it's a different scale. You go to Germany, it's a different scale. Because they've invested in different infrastructure and different workflows to be solved. You go to the How powerful is that? Wouldn't we love that here? We haven't chosen to focus on it. It's all about focus. They're jealous of our e-prescribe. I would trade, I think. I don't know. So famous quote, and it's not March 2nd, so we're time traveling a bit. But the reliability of a ubiquitous solution beats the functional advantages of a technically superior one. People are like, we have to be using fire. Oh, it's so much better. Why is it not working? Well, at the end of the day, I'm gonna use what I can use to communicate with everybody. Period. Full stop. So what are the different architectures? That's the problem set. How do we want to get to ubiquity? How do we build that? There's three main types. Centralized. Build big database. If you're a private company and somehow you get to be that lucky service provider, you have a big database, one input, one place in, one place out, single point of failure, big risk. The more centralized you are, the more risk of when there's a hack or something that it brings down a lot of infrastructure. Change healthcare last year. Not a single point of failure, right? The clearinghouse network is all interconnected, but changes 1/3 of the whole clearinghouse network, 1/3 of providers, 1/3 of payers, roughly. Huge impact for months. To this day, not all the systems are back up. You say, wait a minute, okay, let's federate it out a bit, right? Reduce our risk. Well, that's fine. But you sort of have this tension, right? They're all angling to get more market share. They're all angling to do things a little bit differently as a result. And those differences cause incompatibilities. And then you get down to decentralized, fully decentralized, like Bitcoin or something. And there's huge issues with that. Bad actors even, right? You know, these on-ramps, these gatekeepers of some kind. How do you instill trust? How do you prevent abuse? Is to allow for communication of any network invites bad actors. Fraud is a function of communication. The only fraud deterrent that actually exists is to not communicate. You can go back to your house and you'll never be defrauded, right? If you just go hole up, that wouldn't be a good life. And that's sorry, I don't know who you are. So different architectures. You have on the left, Larry Ellison fever dream. He loves big databases, right? Like Oracle, he's the head of Oracle. And Cerner, right? He bought Cerner because he wants to turn America's healthcare data into a big database. He said it many times. Yeah. I have receipts. And I'm making fun of like the 5th wealthiest man in the world. But then you keep going down. You see SureScript's out. It's the only network, right? And it's ubiquitous, and underneath the hood, it's a big database that just sort of moves things around. Anti-competitive. FTC sued them in 2020 for a monopoly. But that was before Lena Khan, or so. Oh, sorry. You continue on and you see, you get to sort of this record location, which is, we have a few players and we can try kind of figure out where things are, how to route things. And you move further and further and you get to federation. And you start to see a lot of testiness with the federated model. See a lot of people angling for growth. And as they angle for growth, they say, let me test the boundaries of the rules we've set. And we see that manifesting today in the abuses of care quality, of Commonwealth, these health information exchanges that were designed for treatment, but suddenly lawyers are getting data from them. Life insurance is getting data from them because these on-ramps, these various on-ramps are competing for market share. So there are distinct drawbacks. None of these architectures are right or wrong. It's a trade-off. And as you look along different patterns of what problem we're solving, e-prescribing, clinical data exchange, prior auth, you just see different manifestations of them. You go all the way to decentralized. Doesn't work in healthcare because you need a light boundary of trust, but you get Bitcoin and NFT apes and money laundering. So what are some of the barriers? Network development. So if you trace any particular problem set you're trying to solve, provider to provider, provider to pharmacy, pharmacy to PBM, and you're starting to go through that journey of building a network, you see the network founding, there's no value because it's still point to point. It's kind of cool and nifty. You're like, wow, I solved this with my partner. I have to go solve it with partner 2. But as you start to hit that, the network growth becomes very rapid in the value creation. All of a sudden you hit the atomic network at a regional level or state level or some other factor that allows for the right set of trading partners to really 10x the way they were operating. And so you hit this atomic network and you say, wow, we've done it. We've solved it. And then everyone turns their head and they say, oh yeah, let's get in on that. And fraud, abuse, waste, all this stuff comes in and it breaks the rules of the network. You see this time and time again. Visa, founded in California, Bank of America card, expanded nationwide very rapidly. They said, holy shit, we made it. And then all of a sudden, merchants, retail said, hey, we want to be in there. We want to be first-class citizens. We don't want to be mediated through a bank. Broke all the rules, almost destroyed Visa. Then D-Hawk, the leader, this hard ass, he just said, you know what? F you, you're not coming in. We are who we are, powered through it. And now they're, love them or hate them, they're ubiquitous, right? Yeah, I want credit cards aren't the best solution. There's many payment rails, but it's just an example how we see this over and over again. That you have this trial of innovative conflict where somebody says, wait a minute, I can use that network, that infrastructure for a different purpose. That's slightly adjacent, or maybe very adjacent, or not even adjacent at all. And they push it to the brink, and we're there. It consolidates. We see networks, regional networks consolidate. Debit card networks were regionalized. Railroads were regionalized. Any infrastructure, as they get stitched together, you see this growth. And then we hit ubiquity, and then commoditization. That's where prices start to really decrease, because suddenly you're not competing with a regional monopoly. You're not competing. You can only really compete on the price because the network is set. So we're here. We're here particularly for clinical data exchange. Fair Quality, Commonwealth, they provide 75% of providers the ability to pull patient records for treatment purpose of use. Holy moly, how cool is that? That's very few countries in the world have that capability to see the problems, the allergies, the medications of patients and pull that seamlessly without cost. But innovators have entered, and said, wait a minute, mass tort, law firms, they need data. Payers, they need data, for denying claims. And a variety of other things. There's me payers in the room for this this next one. I like to stir the pot. And so all these pressures have caused conflict, disputes. When I saw Oliver last year in April, we were at this conference in DC. I'm like, oh, how fun is it? Nice to meet you. And then the next month, Epic and Particle Health get into this huge dispute about abuses of this network, accused abuses. Like, I cannot comment in one way or the other as a member of the steering committee, but it happened and it led to an antitrust case against Epic that is ongoing. Holy moly, drama. Cognizant and Infosys. People don't know these, but if anyone remembers like the H-1B dispute a couple months ago, after like Apple and Amazon, these companies are all listed. Who are they? Well, they're these service providers for payers, for insurers, and technology providers that bring in tons of skilled Indian labor to immigrate, and so they were called out. They're extremely powerful. They power all the payers, their software and their services, and now they're antitrusting each other. And then you go back to the top one. Point Click Care is the largest skilled nursing facility EHR in the country, and they're getting sued for information blocking. The federal regulation. And so we have all this drama, all this tension that's being manifested and let loose. It's because we're in that messy middle. So speaking of regulation, we're in healthcare. There's a lot of it. Taking a step back, what is, why do we regulate? Government of any country is the product manager for technology, at least in this bubble, the health technology bubble. They set the priority. They're the one source, aside from the whims of the public market and some luck of the, some lucky tailwinds, that can say, we need to make e-prescribing digital. We need to make clinical data digital and potentially see it through. Like any good product manager, they can fail, or they can choose the wrong thing, or they can build poorly. We've seen that. And so they set what our engineers, the vendors, private industry work on. They write the specifications and their regulatory process. They can be very hands-on, like the last administration. They can be very laissez-faire. We'll get rid of regulation and market what the engineers will provide. That could be true. I'm not going to put too much politics into here. So it's currently a very bad time to guess at what's going to happen, but we're going to do it anyway. So a brief overview of what is happening right now. There's a lot of acronyms, so I'm sorry for this. You're not in the weeds on these, but the CMS, the Center for Medicare and Medicaid Services, should be CMMS. No one ever talked about this. has two rules that are out. One is about sending these documents from providers to payers to facilitate claims. It's been out there through like 2 admins, 3 admins. I think they're just keeping it there for fun. It may or may not happen. CMS 0057, this is the prior authorization rule. This is something that probably will happen. There's a lot of attention on prior authorization and the pain it causes providers. That is our current focus. The product managers of the regulators / national product managers of last administration, that was a big focus for them. And it came from even Trump before. And so we'll probably see this requirement of payers to make available digital pathways for prior authorization, which should reduce the administrative burden on provider organizations. Hell yeah, let's get that. Let's get a round of applause for that, right? We got that. And then allow for payers to exchange the claims history as you go from payer to payer, so that you don't just walk into United and they say, "Who are you?" But they say, "Hey, we know that you have X condition. We know that you have these medications. Here are the right programs to get you what you need. Here are providers that are now out of network. We're going to help you find the right ones." That's the ideal. Will United do that? I don't know. But that's what they're intending to do. Provider access, giving providers access to claims data at the point of care. And so with that longitudinal picture of diagnoses, of medications, of providers, then your care team can start to say, okay, actually, I have that fuller picture on top of all the clinical data I have from other providers. Advanced benefits rulemaking. This is part of the price transparency push that's come from Trump, then Biden, now Trump again. He's already released an executive order, one of many, that pushes this forward, that says, you know what, providers and payers, you need to state what your actual prices are. And the idea is that will curb the abuses on either end. So we'll see some prices go up in some places, some prices go down, but push towards a more healthy and transparent level. Will it be effective? No one knows, but it's a good idea. TEFCA, the Trusted Exchange Framework and Common Agreement. Right now, we're stuck at 75% of providers who can exchange clinical data between them. If you're a provider and you use Epic, and you see care everywhere data, and you're like, wow, some cool history. And this applies to most of the major EHRs. But if you're on a behavioral health EHR, if you're on a PT EHR, if you're on these specialty specific and long tail EHRs, you don't have that capability. And to incentivize that, they said, okay, we're going to get the federal government pushing what private industry has done so far through the Trusted Exchange Framework and Common Agreement. This is contentious. This is something where people are like, this might be a Doge target. This might be something that gets cut. Because it's already working well enough. Why do we need the government involved? HTI-2. So this is the newest sort of like, if you take meaningful use, and that started with the Certified Health IT program. This is the latest sort of like update to it. Proposed in the last administration, they couldn't get it finalized in time. So it'll be likely finalized. I imagine them cutting a lot of the things, especially the political things in there about, how should abortion care be shared across state boundaries? How should pronouns be handled? We'll likely see that cut because those were inherently a little bit political in nature. But a lot of this is upgrading the developer experience, creating new digital pathways for provider to payer exchange and provider to public health exchange, which is, there's actually a decent amount of provider to payer health, public health exchange, but it was built in 1992. So it's ancient, crusty. It clearly was not good enough for the last pandemic we had. Hopefully the last one in our lifetime. So, all AI, no crypto. Sorry, crypto fans. Brief breakdown of AI. It's a framework. I should put like framework next to ones that many are familiar with, but just to reiterate, co-pilots. So co-pilots are for any role, not just healthcare, but any role. When you say, you know what, AI can make you 10x better. We're going to have it sit next to you and do the coding. It can write your paper with you. It can, if you're a doctor, it can suggest things. The scribes, AI scribes fall into this category. Those are all co-pilots, right? They're sitting there. They're not replacing you. They're just making you better. VC loves this. Venture capital is obsessed with all the co-pilot variants because they're not scary to you or me, right? They're not replacing anyone. They're making you better. Everyone's can get behind that. What they will do for health information exchange is demand data. right? AI demands data. And so the pressures that we sit, it's funny that AI happens right as we sit at the bottom of that trowel. We're in this, all this strife and conflict. Is it coincidence or is it cause and effect? Because the demands of data are going to increase dramatically. We need to figure out our shit or it's going to break even more. Agents, much higher upside, right? If we can start to say low-level tasks of the developer, low-level tasks of the provider of any role can suddenly be automated, can be autonomous, then we can 10x the care we provide, 10x the development we provide. Scary to people, inherently scary because the upside, the ceiling of that is that we don't have jobs. What do we do? Terminator 2, that sort of thing. And it breaks so many traditional mores and rules and guardrails, and assumptions. Can an AI agent prescribe? Not today, right? Legally, not. Could it? Could it prescribe? Could it place labs and medications and at a higher, more effective, correct rate than providers at some point? If you trace the arc, absolutely. If you trace the arc of compute, absolutely. But it's hard for us to grapple with what that means. And how do we do that safely? And how do we know it's an AI behind that screen and not just a, cerebral send it to to get my ADHD med, right? That's the risk we sit at today. And it scares the shit out of people. It scares me too. And then infrastructure. AI is both the solution and the problem. All these problems that are going to break a lot of the things we have today can be solved a bit with AI. AI is going to make infrastructure better, more resilient, more reliable, more flexible. Oh, I already went through this, but if you're looking for a nice little picture of what it is, AI can be augmentative or autonomous. So co-pilots, they're augmented, they make you better. Be active, right? The ChatGPT. Let me go into ChatGPT, type it in, ask it a question. I've chosen to change my workflow to go do something. Or passive. Having a conversation, records it, summarizes it, sends out the email. I'm having a conversation with a patient, the scribe just passively says, you know what, here's the note, here's some orders I think I heard, here's some diagnoses I heard, is that right? That's why that's getting so much investment, because it's both passive, no workflow changes, and it's not scary. Bridge is the largest AI scribe. It's got $250 million. Agents, you have task specific. So you have these ones that we say, okay, you can't replace a full doctor, but you can certainly do low-level tasks. Or role specific. We say actually BH providers, not that much prescribing, there's not that much lab ordering. Maybe they can do therapy. We haven't made that choice yet, but certainly we could see different roles or specialties be the ones that agents are adopted in first when it comes to providers. So what are we going to see here for health information exchange? Right now, we see a ton of different use cases, right? We see clinical decision support driven by AI. We see HCC coding and care gaps by AI. We see the summarization, visit prep, because it's so hard to wade through all this information. Let me surface the most important bits identified by AI for my specialty or who I am. And then scribes, like I've talked about 3 or 4 times, like everyone loves them. Right now they're monomodal. So they're taking in like 1 or 2 pieces of data, right? They're taking in health information exchange data. They're taking in the passive conversations. Maybe they're taking in 2, but they're not really taking in all of it. So where do we trend? The trend of enterprise B2B software is platforms. I hate to use that word. It's overloaded, just like interoperability, but enterprises don't want to have 25-point solutions. They say, I need why is Epic popular? Because there's one big solution that solves all the specialties. And that trend will continue and will happen here. You heard it here on February 28th, 27th, 2025. And so it's not just note-taking. The scribe is the replacement of all end user tasks, all typing a provider does. Placing the orders, coding the visit, sending the follow-up message. We're gonna see them saturate across all specialties. Right now, scribes and AI is really popular for outpatient because it's easy, right? You're already having that conversation. How do you do that in the ER, right? It doesn't really work as well. How do you do that in different inpatient specialties? But they're going to, right? They're going to figure out how to apply AI and scribes and things like that to every specialty. We're going to see that convergence where it's not just doing note-taking, it's not just scribe, but it's a true co-pilot where it's doing the coding, the care gaps, the visit summary. And we're going to see it add all those input modalities. So we're gonna see that demand on health information exchange to feed into these models. So right now, EHRs can't handle that. Not even Epic. Epic is partnering. They've never partnered in their life, right? Like this was a dirty word when I was at Epic. And suddenly they're partnering with Microsoft and the Bridge, and they're doing it because they don't know what they need to build. So they're this Epic workshop, and they're partnering because they say, hey, what APIs do we need to build? Because these are net new workflows we've never even thought of. They're building them and they're releasing them. And that's Epic. Smaller EHRs don't have the resources to build these new APIs and integration points. So you see screen scraping, RPA, become an extremely popular way to integrate with eClinicalWorks and Athena Health and these mid-market SaaS EHRs, because the web browser and AI makes screen scraping much more resilient and flexible. We're going to see consolidation. People say that the scribe market's going to commoditize and we could drive to zero. They're wrong. What actually is going to happen is that we'll see different winners per segment, just like we see for EHRs, right? Epic is dominant inpatient and these large integrated delivery networks. Athena Health is dominant elsewhere, the general purpose, outpatient, specialty specific EHRs dominate. We'll see solutions sort of align along those EHRs. So you want to go make a bunch of money, make a scribe for some niche specialty. Simple practice, it doesn't have a good scribe. So behavioral health, there, 5%, please. My wife is a social worker and she complains about it all the time. So agents, co-pilots make users more efficient. And that in aggregate adds up to more efficiency for an organization, but not total, because like you suddenly get an hour of your time back. You're like, okay, maybe I'm just gonna go home earlier, right? The doctors are already doing pajama time. So the organization is not accruing the benefits, which will drive organizations to use agents. And so what that means is that we're going to see them look and say, you know, what workflows can I automate? Start with the back office. It's going to be the easy ones, that not the clinicians, because that will cause uproar. But they're already doing it. They're saying, how do I automate the prior auth, the claims denial, all the back office stuff, and it will shift slowly because they're going to see the benefits of these agents. They're going to say, wow, how do we apply this more and more and more? As I mentioned, societal norms. Patients are going to distrust this inherently. Connection is really important for so many communications, and that will persist. And that's actually our enduring mode as humans. So know that you know, until we really think that agents and AI and computers have empathy, have connection. What was that movie, Her, with Joaquin Phoenix, right? Like until that's like real, I didn't actually see it, but like until it's real, then we have a moat of some sort. We're going to see changes to job training, right? When you start as a resident, when you start as a junior developer, you do easy things. Well, those jobs are eliminated. How do we train people? Maybe the AI is training them. Who knows? But dramatically change the path and the arc and the growth of people. That was point 3. Point 2, entry-level jobs will start to be removed. Yeah, role-based agents, we're going to see potentially entire specialties, entire roles disappear. If we see those role-based agents rather than task-based. Regulatory norms are going to be a big barrier to agent adoption. We need to lean in, because it's scary. We need to lean in and pilot this. We need to say, here's how we're going to do it. Here's how we're going to try it out. We're going to see if it's effective in this controlled setting, or innovators are going to go break the rules, right? They're going to go Uber this shit. We do not want them to Uber this. This is really monumental and really important. And so, you know, figuring out how do we pilot, just like they're piloting drones down in Austin or whatever, to see, can the FAA expand it? How do we do agents and AI things in a safe way that we get comfortable, we understand the limits, and then we expand and rapidly improve as a society? Because to ban it, to run away from it, it's inevitable in some way, or we'll be behind other countries that lean into it. And to lean into it fully, there'll be abuses, mass abuses, and mass fraud. Everything that happened with Cerebral and the ADHD pill mills, times 10. So it's just going to break a lot of the assumptions. Like we bake assumptions into our health information exchange. We bake the idea, we say, you know, Dr. Keeler has an MPI, and MPI needs to be used to prescribe. Okay, can't use eligibility, can't use e-prescribing, can't do lab ordering. And so our infrastructure will need to be updated to handle that. It may be not appropriate for what may come there. The networks we built were built with humans, the assumption of humans. And so we're just going to see rules broken, like we were seeing today with the clinical data networks. So, health information exchange, the infrastructure, we tried to beat manual exchanges by saying, let's make it digital. But digital exchanges that we built are inherently inflexible. They're not as ubiquitous, they're not as flexible. We can't fix ubiquity. Ubiquity is a network building problem. It's the hardest product problem you can have in any technology, but we can fix the flexibility problem. Agents make protocols much more flexible. I can receive something and upconvert it. I can send something and have it interpreted midway and send a different protocol. I can send a payload that I don't understand and have it use the right APIs to put it into my EHR. The potential for AI across all these vertices to upgrade our infrastructure, build better infrastructure, is really, really exciting. And so there's this example that came out in the last week of, and it was staged, semi-staged, but like it was a proof point where they had two AIs talking to each other on the phone, and then they switched to a more efficient protocol. And of course, they've been programmed to identify that in some fashion, but you can imagine how our existing infrastructure might use different protocols when AI agents are involved. There's doubt, there's fear, there's uncertainty with AI. And there's every time you talk about use cases, people say, well, it's not good enough. Look at this, how it made a mistake. We make mistakes all the time. And it's a question of, does it make more mistakes than we do? Because once it surpasses that, the question is, what are we afraid of? And the inevitable thing about technology is that this is a compute problem. And every compute problem in technology, you don't bet against compute. You don't bet against the inevitable tide that Moore's law will prove true, that the growth of our performance in technology does not plateau. And so this is the worst AI we'll ever see right now. It's pretty damn impressive. Something to think about. That's it.
Good, perfect time. We have about 15 minutes for questions. I know there are a lot of people with questions. I have questions, but I want to let the audience start. So yeah, go ahead.
Yeah, thanks. That was awesome.
Introduce yourself. Tell us your role.
I'm Austin. I'm one of the Biodesign Innovation Fellows. You mentioned treatment use cases. Where do you see like the future of chronic health monitoring when we have AI? Like you can only pull when you have an exact treatment case right now, or on the other side, you can do like individual right of access with the patient, and that's restrictive. So like, where do you see that going, and how do you enable this?
Current gray zone in the health information exchange, plenty of groups doing that. And so the argument for treatment for this use case, because I can tell you all the gray zone stuff, because it comes up to the steering committee, is that if you're pulling for a population that's been attributed to you as a provider, and you look and you say, hey, I don't need to care for this patient, the decision to not care is a care plan update that can be communicated back to the longitudinal record. And so not everyone agrees with me and others on this, but it's established, people are doing this live on the networks today. And so you start to think about that lens, so long as you have patients you're caring for, then that's treatment by most people. This is a whole section. The solution to this quibbling about the line in treatment, which is infinitely fractal, is to open up the other use cases. It's to allow payment, to allow operations, which is really, really scary to people, right? To have payers pulling clinical data is frightening the providers. My claims will skyrocket. They're going to abuse us in contract negotiations. What I'll say, I can't solve that. I try to, but I will say that when I started 10 years ago, providers weren't communicating over care everywhere and care quality and all these networks, and they were afraid that the doctor down the street was going to steal their patient. Then we got one connected, and two, and then regional atomic network. And guess what? Over time, they said, "Oh my God, this is so much better. We have to get on." And they turned it on by default. So that's my optimism, because I'm eternally optimistic, as I've been opining about everything with Oliver today, is that we're at that, what's the nadir, or what's the bottom? We're at the bottom of this tension, this problem for these use cases, and we're gonna say, okay, let's build the paved paths for operations, for payment, for individual access, And to the point of individual access, we've had the first successful tests on these networks of patients strongly identified. So using like Clear or these other strong identity proofing vendors to say, I'm Brendan, I'm not Lil Wayne, right? Like I'm Brendan. And so that the Lil Wayne problem is if we gave consumers open access, somebody would go and pretend to be Lil Wayne immediately and pull his data. That's a HIPAA breach. That's an abuse of privacy. And so strongly identity proofing is the protection against that, that you say, here's my selfie, here's my signature, here's some documents, and Clear says, yep, or the government says, yep, whoever. And then you use that token to go and pull your data. So they've done it with Epic, they've done it with Athena. And the hope is they scale that because as soon as patients can pull their data, you can do a lot of really nifty things in terms of consumer facing applications, but also really important clerical and administrative things. You can go to life insurance and say, oh yeah, here's my health data, like underwrite it instead of going through all these manual and lengthy processes. You can go to the law firm instead of these abuses that we see for law firms just mass pulling data over treatment inappropriately. Well, now we have this pathway where you do have personal liability you want to go and enforce. You have the right to, but today you have to go stomp down to Stanford and say, hey, HIM department, give me my records I'm entitled to under HIPAA. They hedge and they haul. And so for prior organizations, I think it's a little scary, right? But all of this is scary. We get over the hump because the efficiency, the gains from the reduction in administrative burden are 10x whatever we're afraid of.
That was masterful. Curious, in the transition from the more augmentation co-pilot regime to the more higher agency regime, who do you think are key stakeholders in adoption in healthcare?
So I mean, the governments, right? Like federal, state have to allow it, right? Like licensure and things. There's so many compared to other industries. We have so many compounding rules and regulations, and in this case, we've built them up for very strong reasons that we don't want Brendan being able to prescribe. I didn't, morphine or something, right? Like if I had that superpower as a consumer, we'll see rapid abuse, and so the fear of letting agents prescribe is that we're actually just letting patients choose whatever they want, choose their own adventure healthcare wise, which would lead to worse outcomes and much higher cost. And so there's a mixture of paternalism, but also like the correct amount of guardrails for the power of the healthcare system being harnessed by people that don't know how to use it. If it's all backed by AI, great. But if it's just a front for consumer choice, then we're in trouble. And so that's why I'm very pro, let's find a way to pilot and try it with a specialty or a certain area and then say, oh my God, wow, it's 100x better because we suddenly have capacity to deal with the behavioral health problem situation. I think that's one that sticks in my head because of the lower prescribing rates and things like that. But there's probably other ways to pilot and try it. So regulators are a big part of it. And innovators, I think innovators have to demand it. And probably if you have to try and break the rules, and then people say, okay, rules are broken, that's how you inspire legislators to make law. I hope they'll be inspired to do the right things in terms of being forward thinking, but we see divergence right now. We see legislation trying to ban AI for use by payers because of the true case of payers using AI to deny claims. They're saying, okay, no AI. They do it manually, they will not deny claims. You kidding me? And on the other side, we have Schweikert, Representative Schweikert out of Arizona, passing just saying, going for shooting from the moon, passing one to say, you know what, agents approved by the FDA, AI agents, they can prescribe nationwide, just full bore, which is, that ain't right. So, we see divergence, and I think that the middle ground is one where we say, innovation is good, let's build an ecosystem that other countries and other jurisdictions aren't even thinking about to explore it, to test it. We're all scientists of some sort, and you try it. You build upon your hypotheses. You don't go full bore one way or the other until you have proof points. And the only way we have proof points is if we allow it a little bit. Because right now, the only way to try it out and have the proof points is to break the law or the rules.
Hi, Ron Wayne, position here. Can you speak a bit more about the standards ecosystem for agents? Like I know it's really interesting, right? Like first standards developed for people calling each other, then there's the API world. And I think what you're implying is that we're kind of reaching this post API world where agents are directly
do follow me on LinkedIn.
Yes,
I'm just
a lot about stuff, and I'm just curious, like, if you were to guess, if you were to think of what would be the perfect ecosystem for standards ecosystem, what elements?
Yeah, I mean, so standards are rigid, right? And the demands of agents and the agent workflow are already breaking well past what Fire and HL7 and like the regulators have put in place. And now we're in this pause and no communication zone of the new admin. It's slow, right? Like we see that with every administration turnover. We have a year until they really get anything going again. AI in general, scribes, even just scribes, are racing past the APIs and functionality available from EHRs. And so they're doing RPA, they're doing screen scraping, they're using more ancient protocols, fax, phone call, and using AI to facilitate it. And we can lean into that. And I think we'll see EHRs lean into that because of the prerogative of the information blocking role, which I didn't really get into, but basically says that certified health IT actors, certified health IT vendors, provider organizations, and health information networks can't information block. I was like, what's that? Well, you prevent the flow of EHI, the electronic health information. And the court cases, some of them that relate to that, are really interesting because either, this app is suing Point Click Care and EHR and saying, hey, I've been screen scraping your EHR for 10 years. They have, that's how they integrated. And you never once said anything, but now you have a competitive product and you suddenly block my access with unsolvable captchas, the little type in what sort of 3D. And the district court ruled that the app was okay to screen scrape because it's information blockable. Because the Point Click Care did not offer an API that was equivalent. So you trace that logic, and anything that's done in the UI, in the EHR, needs to be an API, or they could be information blocking. And so I have customers who are doing weird, wonky workflows, right? That they've gone to Epic and they said, hey, you have an API for that. I'm like, no. I'm like, well, how are we supposed to integrate? And they're like, well, the roadmap is so far out, we can't get to it for another 2 years for this particular module. And they're like, well, we need to do this. Like, you have to allow for us to do this. I said, why don't you just screen scrape us? Which Epic would never do. Like, it's impossible for me to imagine 10 years ago. But because of information blocking, we're seeing this slow realization from EHR vendors that they have to, this is the pressure on them to allow either create an API for everything that you can do as a user, allow screen scraping, or allow direct to database access, like some method of doing those things. And that is crazy at scale. And we're just at the start. And there was one other thought here that I lost, but we'll come back to it. But it's really exciting. It's scary for EHR vendors, but very empowering for people developing applications, because now they have this stick to fight back against EHRs. Oh, I remember what it was when this came out, the Cures Act, and information blocking was written in there. Epic got all their hospitals together and they said, we need to push back on this. Everyone said, whoa, Epic, you hate interoperability, you hate your monopoly, all this stuff. But no, they were saying exactly this. They're saying this is crazy if you trace this to the end state. And now you see all these other EHR vendors a couple of years later, 5 years later, 2016, 9 years later, coming to the same realization, saying, oh wow, we need to build a ton of APIs that we have no capacity to build. We need to allow RPA, or we now need to allow direct to database access. They're scared of it, and they should be. And we builders should be excited. We providers should be excited because suddenly we can choose the apps that we want, and there'll be no excuse in terms of connecting it. There will be a way. And if you are a provider and you say, hey, application, why aren't you integrated? And they say, oh, I'm blocked. You say, well, go fix it because you have a path. And if they struggle with it, refer them to me.
One final question.
Yeah, thank you, Abu here. I'm the MBA program here at Stanford. And my question is twofold. The first one, you mentioned like some niche or neglected areas. And so I'm curious what you think those are in terms of like just working towards the future of like more interoperable like infrastructure. And then the second question is more so I think a lot of people see Epic as like the threat, which I mean, a lot of ways it is. It's like, what does Epic have to gain from this? Because I think if you were to like move towards the future, they will have to gain something for it to be possible. And so like, what are your insights into that?
Yeah, two very good questions. Question one, The best way to think about what do we still have left to build from infrastructure is when do you have to pick up the phone and fax something? There's a workflow there that needs to be digitized. So for instance, provider to pharmacy. E-prescription, we solved that, right? I mentioned that earlier. But wait a minute, do I have to figure out, is there stock? Is it in stock when I prescribe it? So I send it to CVS for Oliver goes to pick it up. And it's not, there's none there. Well, shit, well, why can't I know that immediately? Yeah, like, I mean, that is a workflow. So stock transfer for the provider pharmacy, unsolved. And so anytime you say, oh, I have to make a call to figure that out, I have to make a fax to figure that out, you've fallen back to the flexible catch-all. That means that we haven't properly digitized that workflow. And it could be, very easily, could we surface both the eligibility for a medication and the stock, but we just need to be able to build those rails. Another one that I love, talked a lot about earlier when we got coffee, is image exchange. So in the Netherlands, it's ubiquitous. Here has not been a prerogative at all. They've ignored it in the US. It's that private vendors are taking care of it. Not true, right? And how impactful would it be for physicians to have access to prior radiology images? For provider organizations, how much money would be saved for not having to do MRIs or other diagnostics? It's crazy to me. It's absolutely crazy. So when I'm the head of the AST, this is my campaign.
There's
then-
one more question about Epic.
Yeah,
Yeah, like, what does Epic have to gain?
yeah, and so
That's the question.
Epic is the Patriots. Epic is Kansas City Chiefs, right? Like they're in shop. People, well, now they've been knocked down. I'm from Philadelphia, go Birds. But Epic, any dominant party, people resent and revile and view nefariously. They deserve some of that, but they are trying really hard. And here's the thing: their focus is on how do we help providers do things and not how do we help developers. And so anyone who's innovating and building, so I am frustrated. I am so frustrated, and providers must be frustrated. But you talk to a lot of providers and they say, well, Epic's better than Oracle or certain, or definitely better than CloudWorks. And so, there's a difference in opinion there that's kind of, I think people fall victim to their own incentives and their own worldview and their own echo chamber. And that's not to say that Epic isn't guilty. They're guilty of plenty of things, but they're not trying to do bad in this world, and they're definitely trying to help providers. I think I would just say, in a world without Epic, what is the alternative right now? And it's Oracle Cerner or it's Meditech. And I'm not a provider, but any provider can make their own call about what that's like.
All right, we're at time, we're a little beyond time. Thank you so much. I think it was awesome, and it'll be available online as well. So
Thank you.
yeah, thank you very much.
Thank you all.
Thank you so much.
Thanks, Oliver.